will be shocked if there is no OS benefit. I will be shocked.
And you mentioned the delta between the curves. I think it was over 13 months, like 13 and a half
15.8.
15.8.
Yep.
That's really extraordinary.
Yeah,
Amazing
I was
data.
impressed.
Now, what about the clinical response data, the objective response? It was like 85%.
Exactly. Yeah, response rate was higher too. And even in later on setting, and my experience has been when there is a HER2 positive patient, when I have one shot to treat my patient, when I'm about to lose my patient, when I have one shot, T-Dxd has been my bet.
And that's the highest response rate I've ever seen for
Exactly.
HER2 positive metastatic disease.
Yep.
That's unprecedented.
Yeah, think about those. I do have those patients come to me with liver mets and with brain mets, and they are at the edge of organ failure. When I had one shot to treat them, I'd rather give them the treatment with the highest response rate.
That also reminds me, you mentioned brain metastasis. I think about 6% of the patients in this trial had stable brain metastasis.
Yeah, exactly.
But it was stable only, not active brain mets,
active.
I believe, at DB09.
Yeah, but my perception about the brain mets totally shift. Initially, my stereotype would be T-Dxd was a large molecule of ADC. It may not penetrate the blood-brain barrier as well. But after I look at all the data, and actually the data in the brain mets patient are really impressive.
It's really impressive.
Yeah.
I would argue that the Destiny Breast 12 data on T-Dxd and HER2 positive brain mets was extraordinary in as much as the intracranial response rate mirrored that of the extracranial response rate, which I've never seen with any agent. And so T-Dxd is the single most active agent now against HER2 positive brain metastasis.
Exactly.
More so than the HER2 Climb tucatinib-based regimen.
Yeah, and I do have a patient with active brain mets progressed on the HER2 Climb regimen. They still respond very well to T-Dxd. Wow. I'm convinced.
That's very interesting and exciting. Now, the response durability was also like over 39 months, or extraordinary result also. So durability plus high fraction of responders. And then I understand there were about 15% or so that had complete clinical responses, almost double that of the control arm. What's special and what's unique about these exceptional responders who get complete responses?
That question always comes. It's not only the patient, and I start to wonder, can we quote unquote cure them? Especially when they have a durable CR in the metastatic setting. And we all have those exceptional responders that they have been NED for years. And we start to wonder, did we cure them?
Right.
Of course, the long-term perception has been when it's metastatic, we can no longer cure anybody, but with more effective regimen, and I start to wonder, for exceptional responders, would that be the goal in future? Yeah.
A couple other efficacy endpoints were reported at ASCO. PFS2 was significantly prolonged in the experimental arm. Does that mean anything to you? Do you watch PFS2 much in these randomized trials, or is it just kind of an interesting endpoint in passing? What do you think about it?
Yeah, I do look at them, but typically that will not be the primary drivers for me to recommend a regimen and for me to change the practice. It's an interesting endpoint to look at.
Agreed. And then how about the OS data? Was there any signal there numerically? Were you impressed at anything with the OS?
Yeah, so
it was interim, immature.
It was interim, immature, but I will be shocked if there is no OS benefit. I will be shocked.
And sometimes PFS2 can foreshadow an OS signal in some large phase 3 trials, if there's enough statistical power.
Yeah.
Yeah, that's really quite extraordinary.